Assalamu alaikum wa rahmatullahi wa barakatuh. Respected brothers and my dear friends, I'd like to thank the field members who have given the surgical team an opportunity to present on acute abdomen. Our aim is to identify sick patients who present with acute abdominal pain, and the objective is to learn the management of patients presenting with acute abdomen. If you come across patients present with abdominal pain, we have to decide, number one, whether the patient needs to go directly to operating room or he needs to be admitted for resuscitation and observation, or can he be safely discharged. However, this could be the most dangerous course, so one has to be very sure before discharging any patient that you have ruled out any serious surgical pathology, especially in patients who are elderly, patients who are diabetic, and patients who are on steroids and immunosuppression. With regards to the age, if you come across young female patient, one has to be aware of ectopic pregnancy. And if you come across any elderly patient, you need to be thinking in terms of diverticulitis or cancer. With regards to duration of the pain can be acute or sudden in onset, which is seen in ruptured AAA, burst appendix or gallbladder, perforated duodenal ulcer or perforated bowel. Acute pain is also seen in testicular torsion, ovarian torsion, and sigmoid volvulus. It can also be seen in somebody who's got peripheral vascular disease with a known AF, wherein you need to be suspecting an ischemic bowel. Acute pain can also be seen in someone who has CBD stone or renal stone. The pain could be gradual or persistent in situations such as colitis, urosepsis, appendicitis, or pancreatitis. The pain could be intermittent and crampy, which is classically seen in intestinal obstruction. Remember, colonic cancers are usually painless, and so are diverticular bleeds. Moving on to the character and timing of the pain, it can be crampy in case of gynecological cause or bowel pathology. It can be dull ache, such as seen in appendicitis or Crohn's flare-up. You can have shooting pain, which is seen in testicular torsion and renal colic. It can be sharp, which is seen in pancreatitis, perforated viscous, or peritonitis. The pain can be colicky, such as seen in renal colic, and in biliary colic, there is an underlying pain with intermittent exacerbation. With regards to radiation, loin to groin radiation is seen in renal colic and ovarian torsion. Epigastric pain radiating to the back is commonly seen in pancreatitis and perforated duodenal ulcer. Cholecystitis can present with right upper quadrant pain radiating to the back. And in someone who presents with shoulder tip pain, you need to be thinking in terms of, am I dealing with a ruptured ectopic pregnancy or a leaking AAA? Moving on to exacerbation and relieving factors, patients with pancreatitis feel that the pain is better if they lean forwards. In patients with gastric ulcer, the pain gets worse after eating, and in duodenal ulcer, the pain is slightly better after a meal. In cholecystitis, the pain gets worse after a fatty meal. With regards to movement, in peritonitis, the pain gets worse on movements, especially coughing. Quickly moving on to associated symptoms, you need to be asking about history of any temperature, vomiting, whether the vomiting consists of blood or bile. You need to be asking history of any urinary tract infection such as dysuria, frequency, or hematuria. Bowel symptoms such as constipation, diarrhea, or melena. To rule out any underlying malignancy, you need to be asking about history of weight loss or anorexia. If someone is clearly jaundiced, then you need to be asking history of any pale stools dark urine or pruritus. And of course, in female patient, don't forget menstrual history and any PV discharge. With regards to severity, if the pain is disproportionate to the examination findings, then you need to be thinking in terms of, am I dealing with ischemic bowel, especially in patients who have peripheral vascular disease and known AF. A quick ABG with a high lactate and raised white cell count should lead you towards your diagnosis. With regards to past medical history, from the surgical point of view, it is very important to know whether the patient had undergone any previous surgeries, any other medical condition which may increase the morbidity and mortality following the surgery, any family history of cancers or ischemic heart disease or diabetes. Quickly moving on to the vital signs, tachycardia, hypotension and tachypnea should alert you that you are dealing with the sick patient. Fever may be a very late sign. On palpation, look for generalized guarding rigidity and rebound tenderness, which may suggest peritonitis. Listen to the bowel sounds. It may be absent in situations such as diverticulitis, peritonitis, or ischemic bowel. You may hear tinkling bowel sounds in intestinal obstruction. However, bowel sounds are very unreliable. If the patient has abdominal distension, then it could be due to intra or extra-enteric gas or fluid. If it is fluid, you need to be thinking, am I dealing with a leaking AAA or a ruptured ectopic pregnancy? Moving on to the lab results, I'm sure I don't need to spend more time here. Raised white cell count suggests of infection. However, it takes at least few hours for the white cell count to be elevated. Urine dipsticks to rule out pregnancy test, UTI, and if the patient has microscopic hematuria, think in terms of renal colic and get a CT KUB. Erect chest X-ray to look for free air under the diaphragm, secondary to visceral perforation, which may be obvious in 50 to 60% of the cases. Not having free air under the diaphragm does not exclude visceral perforation. It has to be a clinical decision. An abdominal X-ray might show evidence of obstruction. In case of small bowel, you need to be looking for valvulae conniventus. In large bowel obstruction, there may not be any air in the rectum. And in case of sigmoid volvulus, you might see a coffee bean appearance in the left ilia fossa. Ultrasound scan would be a good investigation of choice for biliary pathology, ectopic pregnancy, gynecological pathology, and it could be unreliable to rule out appendicitis and renal stones. However, this could be technician-dependent skill. CT scan is probably the best investigation of choice for somebody who has an acute abdomen. Please get the CT scan only if the patient is hemodynamically stable. Do not transfer an unstable patient into the radiology department. You need to be thinking whether this patient needs to go straight to the operating room. Just to summarize, the initial management and resuscitation for any surgical patient: give the patient some oxygen, good analgesia, keep them nilbum out, start them on some fluids, get a chest X-ray and abdominal X-ray, do some routine bloods including CRP and amylase or lipase. Make sure you have a group and save, and in case of AAA or ruptured ectopic pregnancy, make sure you cross match 6 units of blood. Get an urgent ABG to look for acidosis, raised lactate, and in patients with pancreatitis, obstruction, sepsis, and retention, make sure you catheterize the patient. And of course, call the surgeon for help. Now I shall be moving on to surgical pathologies depending on the various sites. For all practical reasons, divided abdomen into 4 quadrants: the right upper quadrant, left upper quadrant, right iliac fossa, and left iliac fossa. Now moving on to right upper quadrant pathologies, the commonest are perforated ulcer, biliary pathology such as cholecystitis, cholangitis secondary to CVD stone, pancreatitis, pain secondary to stretching of the liver capsule, subphrenic abscess, and bear in mind, very rarely, a retrocecal appendicitis can also present as right upper quadrant pain. In an elderly patient with right upper quadrant pain, you need to be thinking in terms of whether this patient has got an underlying hepatic flexure malignancy or a pancreatic cancer. Other cause could be right-sided pyelonephritis. Moving on to the left upper quadrant, the most important structure is spleen. So kindly rule out any splenic rupture, infarction, or abscess. Other causes are pancreatitis, left subphrenic abscess, peptic ulcer disease, splenic flexure tumor, and pyelonephritis. Moving on to right iliac fossa, commonest causes are appendicitis, right renal colic, incarcerated right inguinal hernia, Crohn's flare-up, young patients with mesenteric adenitis, females with ovarian pathology and ectopic pregnancy, ruptured AAA or iliac aneurysm, right-sided rectus sheath hematoma, or perforated appendix or cecum. Moving on to left iliac fossa, the commonest cause is diverticulitis, left renal colic, incarcerated left inguinal hernia in female patients, ovarian pathology and ectopic pregnancy. Other causes are ruptured AAA or iliac aneurysms, left-sided rectus sheath hematoma. In someone who presents with generalized tenderness, with guarding and rigidity, one needs to be thinking in terms of perforated viscous, pancreatitis, mesenteric ischemia, ruptured AAA, or incarcerated hernia. I would like to thank you all for your kind attention, and inshallah, in the next week, we shall try to cover as many topics as possible depending on your interest and feedback. I would also like to thank Zahiruddin Faiz, who helped me to create this video. Jazakallahu khairan.